Good afternoon, everybody. Thank you very much, Rian. Thanks for the introduction. Can I first say, that isn't me on the screen, that's my CEO. Paul Johnson, unfortunately, got taken sick earlier on, so I've stood in his shoes, and they are big shoes. But I am excited today to talk about the human factors of infection control and prevention, and what we can do to improve systems, particularly in healthcare. So as Rian mentioned, I've got our esteemed colleague and friend, Pelagia, who will introduce herself, and then Chris Gibson, who will then follow.
Good afternoon, ladies and gents. Real privilege to be here. Chris Gibson is the name. I'm ex-colonel from the military. My last job was chief instructor of the Defence Collective Training Centre, which did collective assurance for our deployed hospital care, be that trauma hospitals deploying to the forward shore, or indeed our capability that we designed in training for West Africa when the Ebola outbreak occurred. That capability, which Pelagia helped me greatly in designing and assuring, became the highest rated capability ever assured by the World Health Organization. So some of what we are going to talk about comes from the hard yards and definitely the tears of trying to get it right. So we're going to do a bit of storytelling today about what we did well, what we got wrong, and how those lessons transfer into your world. So any questions? I think we're going to do some question and answers at the end, but we're delighted to take them. Please challenge us. We know your world doesn't always look like ours, but there's some middle sweet spot that we can actually find commonality with. So thank you.
Thank you, Chris. And I think we'll start this session off by perhaps just setting the scene, Chris. And I think you wanted to talk about the world that we live in. And the key points that we're going to cover off in our presentation today, infection control and the most extreme measures and learnings that we can take, the importance of psychological safety and the people factor, and the role of technology and how that can play such a positive role in prevention and control. So Chris, would you mind giving us your insight into the world that we live in?
Well, this term VUCA, which some of you may be really familiar with already, is certainly when I go to support NHS trusts, private care homes, or healthcare providers, is something that resonates as strongly as it did when it was invented by Warren Bennis in 1987, as it does today in 2023. You know, we live in a really complex, volatile, uncertain setup, and that creates ambiguity, not clear decision making, and where errors through human factors can occur. So if we understand that from the outset, and we also have a baseline that nobody comes into work to do a bad job, that we can start understanding how we can create unity of effort and the appropriate psychological safety to allow people to come and flourish within the workplace. So some solutions, there's Professor Keith Grint talks about wicked and tame problems. Some of the issues that you face today are wicked. There's no elegant solution to some of the issues that you have in healthcare. And we have to, through leadership and this unity of effort that I'll go on to talk about going forward in this chat, we'll find that common ground where a solution can be found, but it may not be the elegant one that we strive for every time. So if we use that as the baseline, that this is the world that we step into every time we go into work, that we have that commonality then, and great and deeper understanding that there isn't always an elegant solution to the problems that we're faced with. So that's the starting point, and I just wanted to get that across when we take this conversation forward, so thanks.
So when we're talking about infection prevention, I cannot emphasize the importance of hand hygiene. And from that slide there, you can see the Dr. Nicholas Semmelweis. He was the gentleman that in the 17th century discovered that if you actually clean your hands, then you can prevent infections. Now, for those of you that work in healthcare, you will know that we bang on and on about hand hygiene as a solution to prevention of infections. Now, when he discovered this, it took decades before anyone in the medical world would accept the theory and would accept the principle that hand hygiene is effective in preventing infections. I'll cast you forward to a few years ago in West Africa, in Sierra Leone, in a facility where we were looking after Ebola patients. Now, having worked in the NHS and in nursing homes, in primary care, in secondary care, I do bang on about hand hygiene and taking your gloves off and washing your hands. And now we were out there in West Africa. We had a new message now. We had a direct threat to your own personal safety. So hand hygiene was really key. But the practitioners or anyone that went into that facility had to wear gloves. They had to wear the coveralls. They had to wear Wellington boots. Hand hygiene was still key to that. Now, the Semmelweis effect or phenomenon is such that people are reluctant to receive new evidence or new ideas because they have entrenched beliefs. They have things that work. So having preached to all healthcare workers that you need to wash your hands, take your gloves off, now we had a different message. And the message now was, keep your gloves on, wash your gloves. Now, if I tell anyone in the NHS now to wash their gloves, they'll probably would kill me. And the infection control practitioners really would kill me. But that's what was required to keep us safe in that environment, to wash those gloves in chlorine. So the message here is that the healthcare settings are so volatile. They are so, the infectious agent was so unknown, and the ambiguity of the symptoms, what you're dealing with. So going back to that booker meant that you needed a new message. And this demonstrates the volatility of healthcare settings and how that messaging then is carried on in order to continue to provide, one, patient safety, and two, your staff safety. So these challenges feed into those things that you face in the NHS. So, or in any healthcare setting, primary care, nursing homes, what are the challenges? Often it's because the environment is very, very busy and people don't have the time to look at what is actually happening. They don't have the time to stop and think. So actually complying with infection prevention becomes such a challenge. So beyond looking at the checklist, the infection control checklist, there is also the human factors that you have to take into account. What is it that makes someone not comply with hand hygiene when they know that hand hygiene will improve patient outcomes? So is it the setting? Is it the resources? Is it the training and education? Is it the communication? Now I will come to one solution that we came up, we implemented in the Ebola setting. Going back to the Ebola setting, we implemented a solution of doffing, which is taking off your PPE with two people. So a PPE monitor would watch you. So people were exhausted, and you can see only tiredness and all that comes into you. So you'd come out of the facility and you would have someone literally directing you to peel off your PPE. So you can imagine some of the surgeons, probably they were working in that facility as a general doctor. Surgeons are used to just peeling off their PPE and get on with it. Now you were having to instruct them to pick up the glove and peel it off and wash your hands. Pick up the next glove, peel it off and wash your hands. So those are the challenges in putting systems in place to ensure your safety. How do you monitor those challenges? How do you track those challenges? That is where really we might want to think of the solutions. And when there's a PPE breach, how do you then record that? How do you analyze the effect and the long-term impacts?
Thank you, Pelagia. Yeah, that's really interesting. And Chris, I know you also worked in West Africa and implemented a really successful program of change. Can you perhaps give our audience today a bit of a backstory as to how that came about and what were the key findings?
So the task that we got with regard to Ebola was one that we didn't search for. It came knocking at the door at really quick pace. We thought that the NGO community would be appropriately looking after the emerging pandemic in West Africa. I actually went on holiday with my children. I was a widower at the time, and I spoke to my boss and said, look, is it okay to go and leave? We were just coming out of Afghanistan, running the trauma hospital matrix in Afghanistan. It had been really hard work. And he said, no, we're definitely not on point. You know, off you go. And I was lying on a beach in Greece with the two boys, and the phone went and said, the boss said, where are you? I said, well, I'm on the beach. You told me to go on holiday. Well, get back. How dare you take holiday? And we're on point for Ebola, and you've got 5 weeks to design a first world hospital in the rigor of a West African jungle and have it working. And by the way, it's against the Cat4 pathogen Ebola virus disease. And we want to deliver for the highest level of care, UK standard, in that environment. Off you go. So what did we learn? Well, and there's a slide coming up which I'll introduce briefly to, where we had to understand 3 components of an organization. And if you can look at your own organization through this lens, it becomes really important. The physical environment that you design, so we can all find a budget from somewhere which designs a really nice capability. The conceptual component, which basically creates the conditions for your operating procedures and tactics and techniques and procedures as well. But more importantly is the moral component. How do you get your people to turn up and deliver first world care, knowing that they're dealing with a virus which could be detrimental greatly to their health? And we had that with COVID. And if you don't create all 3 of those conditions with equal parity, you'll not be able to deliver a high-performing capability. So moral, physical, and conceptual components all have to be looked at in the same way. If you don't get that moral piece right and the psychological safety is not there, you can start seeing some of this culture come through. So we talked about in defense about vowels. So B and then all of the vowels, where you start seeing a lack of motivation, a lack of reward, a lack of empowerment, resistance to change, and a lack of recognition. So I've seen that in healthcare settings. It's not unrealistic to say some of that goes on. I've seen staff surveys from trusts in the last week, which highlight this is still happening today. But if we recognize it, if we can identify it, we can close upon it. Because if it does occur, the slide on the right highlights the impact that has. And I know for those sitting in the back, you might not be able to read that, but I'll just pull some of the stats out. 48% intentionally decreased their work effort. So they went out of their way to say, I'm not doing it. 80% lost time worrying. So, and the stats go on and on. So there's an absolute direct causality between that on the left and that on the right. And as leaders in healthcare, it's incumbent on us to recognize it, call it out, and close that delta. Because if you don't, we'll start getting never events occurring. So recognize it and close the gap really quickly. And certainly that's what I've always tried to do with the capabilities that I've been involved in. And it works. The trauma hospital in Afghanistan had the highest survival rates in the history of medicine, 98.6% survival rate of any patient that walked in there. The highest in the history of medicine. The Ebola treatment center that we created, 100% assurance rating from the United Nations, the highest ever given in the history of the United Nations. All because we recognize this and the detriment it has on our staff. And if you can close that gap, you will reduce the never events and you will increase staff engagement. So,
Chris, can you perhaps talk to us a little bit about the consequences of that and how did that manifest in positive change?
So everything leads to the patient. I don't need to tell this audience that the patient sits at the center of everything we do. It's the reason we turn up for work. regardless of if you're in finance, administration, non-clinical roles, the reason that you're employed is to deliver the best care possible to that individual that walks or is carried into your facility. And we had a great privilege in defense of going for 6 months, reflecting on our learning, training with that learning in mind, and going back in. So we know you don't have that luxury, but our learning was really powerful and absolutely titrates into the National Health Service or private healthcare. But these are some of the facets that we built. So it's not rocket science, this moral component and how you build it. But that unity of effort, building of trust, looking at resilience and how to support our people, really caring for our people, absolutely made a difference. Leadership has a huge impact on the performance of your capability, your hospital, your care home. You know, we could see it when you talk about helicopter view or a balcony view. Our collective training facility was a complete facsimile of the hospital that our staff were going to deploy to. So we could sit on a balcony and have everything laid out exactly as it would be in that hospital, down to a piece of paper. CT machines, MRI, surgical, ITU, resus, etc., etc. So when we saw a leadership team that needed development, we could see the consequence of that ripple throughout the organization. Those that had great leadership, we could see the positive effect titrating through the organization, where people were empowered because they knew what their 1 and 2 up actually wanted from them. And they would just get on and inform routinely because they knew they were working within the intent. When there was leadership that needed development, that never happened. And it froze the organization. People would make mistakes. So you'd have independent activity going on, which was not conforming to the unity of effort that we required. So
I think you will find that for most of you that works during the pandemic, the COVID pandemic, you will recognize that the structures that were put in by trusts or your organizations or in care homes, and how those meetings that you had, those aftercare, those after outbreak meetings that you had, that feeds into tracking what is actually happening with the organization, and encourage a culture of ongoing learning, a culture of learning from the incidents that happen.
So the slide up just now is what became our main battle tank in defeating Ebola virus disease through high standard healthcare provision. So we were about a week, 2 weeks into training of our international teams that were deploying, and those international teams came from within a diverse spectrum within the UK. They came from the Republic of Ireland, they came from Norway, Sweden, Canada, and Denmark. All different ethical roles and responsibilities with regard to it. So there was a clash of cultures with regard to what could be the highest level of care. But we unpacked that, we created a unity of effort, but we were still not seeing the levels of performance that were really required to deliver first world care. And when we wound back and reflected on why that could be, it was because that moral component hadn't been addressed. We hadn't looked, we were too busy in telling government that we had this hospital ready to go. So our looking up became the most important, where actually looking down and in to our staff was actually the real focus of where our activity should have been. And when we could assure our staff and find a mechanism of assuring our staff that they were going to be safe working in that environment and that we would really care for them whilst they were in there, or if in the worst case scenario they got Ebola, we started to get higher levels of care. It was transparent. We saw it. It was transformational. Within a day of being able to do this, we were able to raise the bar on the delivery of levels within the hospital. And the way we did it, and this is why we've aligned with Radar, because we had to design on the back of a cigarette packet, not good for healthcare providers, a digital mechanism of assurance. So we're in the facility that we designed for training purposes. we had to find a subjective viral load. So we used a fluorescing dye, which is very common in infection prevention control training, but the one we found dissipated on contact with chlorine completely. So, and chlorine was the disinfectant that we're using for the facility out in Sierra Leone. So when we found that, we had a bit of a eureka moment and say, well, we've got a subjective viral load that can show causality and effect of the transference of infection throughout the facility. So we started using that on all this. If you go back a bit, Simon, sorry. If we started using that, as you can see on the far left, when people had completed their shift, we would body map them. We created a software solution which would capture the points of contact for where fluorescence was. We would map that digitally. We would look at that digital readout. We would look at our operating procedures, and we would adjust if there was too much of a risk, or if we had multiple contacts in similar spots. Every single activity was filmed, and we'd review the films, look at where that was happening, see if we could adjust our practice to mitigate that risk, and then we'd go on from there. And we'd do it again once they'd doffed, and we'd reassess, and we'd keep doing that until we got minimal contact. If we got minimal contact, we could show staff where we were at the start of this process and where we were at the end, where there was not even a microdot of fluorescence occurring. We were starting to believe that we were getting somewhere. And because we believed it, we shared that really openly with all the staff. They started to understand that this process that we'd created for the delivery of first world care was viable, and they weren't going to contract this illness.
But even despite all those efforts, Pelagia, you told me an amazing story about the Wellington boot. Would you mind sharing that to our audience?
The long and short of it, as you know, that the fluorescent dye will show where the contamination is. And after all the drills had been refined and everything was absolutely fantastic, we started to notice at about the 48-hour point that people were coming out, and when we mapped them out, when we looked at if there's any contamination, there was contamination almost always in the Wellington boots. Now, that was the only piece of equipment really, and their scraps, that would leave the facility. The rest was disposable. So there was a high risk that we could end up taking Ebola from the facility and taking it back to the accommodation. Working backwards to look at what the root cause analysis was, it was literally down to the equipment and not having a piece of equipment to clean the boots. So during those drills, whilst we were cleaning everything else, the end result was that the boots were not being cleaned effectively because the equipment wasn't there. So they were stepping into the chlorine and stepping out, and there was still the fluorescent dye, which represented the Ebola. And what was needed for that cleaning of the boots was a 1 pound tool that we have in our household every day, a bog brush. That's all we needed to clean the boots. So once that was introduced, then the decontamination was complete and no sign of any contamination, and we could safely reassure all the practitioners that the bog brush saved Ebola. But yeah, the bog brush was
the saviour. Fantastic. Thank you so much.